This discussion is going to focus on the biomechanics at the knee joint. So looking at the knee joint, we're essentially looking at two joints that kind of work together. We obviously have the actual, what we'd consider the actual knee joint itself, which would be your tibiofemoral joint. And it's important to note anatomically some things when we look at some of the bony anatomy. So if we look at the difference in the size of the femoral condyles, and you could kind of see this in the picture, is that the medial femoral condyle is larger than the lateral, and part of that has to do with the position of the femur. So remember, the femur is not just this bone that's straight up and down, it kind of comes down at an angle. So we have a bigger medial femoral condyle relative to the lateral femoral condyle. And we also talk about, when we're looking at the knee, the patellofemoral joint, so the articulation of the patella as it relates to the knee. And the patella articulates within the intercondylar fossa, okay? So in the intercondylar fossa, we call that same region the trochlear groove inside. So obviously we're looking at this area right in here, okay, where the patella will actually articulate. And the basic function of the patella is to basically allow for increased efficiency and torque of the knee extensors. So as the patellar tendon kind of comes across the knee joint, by having the patella, you actually allow for increased strength of the quadricep. And it also does have some protective function to the anterior knee. So there are obviously soft tissue structures and everything that it protects. That would be another function of the patella as well. And if we look at the patellofemoral joint as far as the source of stability, there's an increased anterior projection of the lateral condyle. So it's a little harder to see this aspect of it, but this anterior portion of the lateral femoral condyle, and you could feel this on yourself even, comes out a little bit more anteriorly than the medial does. So what that does is it provides a little bit of added stability to the patellofemoral joint. So looking at the tibiofemoral joint, so go back to the actual knee joint itself, we actually have 2 degrees freedom of motion. So the knee joint is classified as a modified hinge joint. The reason why it's a modified hinge joint is because you do have 2 degrees freedom of motion. We obviously have flexion and extension, but you can do some rotation of the tibia. The caveat to it is that the knee has to be flexed. So when the knee's fully extended and locked out, you can't do tibial rotation, but with the knee flexed, you can. The convex-concave relationship, so you have the convex femoral condyles on the concave tibia. And we'll talk more about the glide and roll relationship later on. It's just important to note that rolling at the beginning of any of the ranges of motion, rolling is actually the predominant motion at the beginning, and it slides or glides more at the end of range of motion. And we'll talk a little bit about the relationship between the roll and slide and what that means, because again, here we're going to get more into looking at closed chain versus open chain, because again, that's a little bit more, the closed chain aspect of this as we're looking at the lower extremity is a little bit more important than it is for the upper extremity, because again, you know, functionally for individuals, your upper body tends to work more in an open chain, whereas your lower body will work a little bit more in a closed chain. So part of the stability at the tibiofemoral joint comes from the menisci. Okay, so when we look at the medial and lateral meniscus, they allow for more stability. They also allow for a larger range of motion to take place at the knee. So if you were just to look at the bony anatomy of the knee, you would say, well, the knee is not a very stable structure, but because of these deep menisci, they allow for much more stability, and they also help with the range of motion. So when we look at the menisci, so when we look at the shape and which one is more mobile, so if we look at the shape, So the medial meniscus is a little bit more C-shaped, whereas the lateral meniscus is a little bit more O-shaped. And we'll be able to see that on actually a little bit better on the next slide. There's a picture that will show that. The lateral meniscus is also much more mobile. So the medial meniscus has some other soft tissue structures that attach to it, whereas the lateral meniscus has a little bit more mobility to it because it doesn't have as many structures attached to it. So other attachments at the menisci, so you have the transverse ligament. So these are some soft tissue structures that are important to note anatomically in their relationship. So the transverse ligament is the ligament that connects the anterior horns of the two menisci together. You have the meniscopatellar ligament. So again, sometimes you just think of the names meniscopatellar. So they're going from the meniscus to the patella. So the patellar tendon rather. The anterior horns of both menisci have an attachment to the patellar tendon. The MCL would obviously have an attachment to the medial meniscus, so the MCL and the medial meniscus have are actually connected. The semimembranosus is an attachment to the posterior edge of the medial meniscus, so that's important to consider with the relationship with the hamstring muscles. The popliteus attaches to the posterior edge of the lateral meniscus. And then you also have the meniscofemoral ligaments. Again, meniscofemoral. So from the lateral meniscus, the posterior portion, go to the inside of the medial condyle is your meniscofemoral ligament. And then you have the coronary ligaments, which anchor the menisci to the tibia. So the coronary ligaments are the ligaments that actually attach the meniscus to the tibia. Again, we talked about the different shapes and which one's more mobile, and we'll get to see the shape aspect of the meniscus a little bit more on the next slide. So here you get to see, again, all those structures we just talked about, plus you also get a little greater appreciation for the shape. So you see here's the medial meniscus, a little bit more of a C-shaped meniscus, and over here you have the lateral meniscus, which is a little bit more of an O shape, and then you have all the other structures that we just talked about and their relationship to the menisci. So important to note, again, we talked about in addition to allowing for stability at the knee, there's also the ability to help with range of motion. So the menisci do move with our knee motion. They tend to move more anteriorly with knee extension and posteriorly with knee flexion. And again, that just allows for greater surface area for that movement to take place. They're going to move both actively and passively. So if you think about the attachments that we just talked about with each one of the meniscus, they'll get their anterior movement through the meniscopatellar ligaments, and they'll move posteriorly through active contraction from the semimembranosus and the popliteus. Okay, so the semimembranosus and popliteus, they're muscles, so they'll actively pull on the menisci when they have to go posteriorly. When they go to move anteriorly, it's a little bit more passive by the meniscopatellar ligaments. So the purposes of the menisci, again, we sort of talked about this already. We'll talk about some other functions with it. Obviously, they help to deepen the knee joint, so they create more stability at the joint. They help to distribute forces based on increased contact area and congruency, so they just kind of allow forces to be kind of displaced throughout the knee a little bit better. They allow for joint lubrication. They prevent joint capsule impingement. So we know that we have a joint capsule that surrounds the knee joint. Well, the menisci kind of take up some space to prevent any type of impingement. And they are a partial protection against excessive movement. So, you know, obviously if there's an extreme force or something like that, that could cause damage to any structure in the knee joint. But for the most part, they also have that other protective mechanism as far as being able to prevent excessive movement. The greatest amount of weight bearing they have is actually with hyperextension. So with particularly with an individual who kind of has a natural propensity towards having a hyperextended knee, they will bear a little bit more weight in that type of posture. So in looking at the ligaments, because we know they provide a great deal of stability, we have the collateral ligaments. So if we think about the MCL and LCL, so the MCL is going, they're both going to resist forces in the frontal plane. So when we look at the MCL, they are going to provide a resistance to a valgus force, whereas the LCL is going to provide a resistance to a varus force. The MCL is essentially a thickening of the medial joint capsule. And when we're looking at where it's going to kind of become a little bit more taut versus having more slack, the anterior portion of the MCL is going to be more taut in flexion. The posterior aspect is going to be more taut in extension, meaning that portion of the MCL is going to tighten up with those different ranges of motion. And the force application with the knee extended is actually supported by other structures. When it's flexed, it's primarily the MCL. So in other words, when you have a valgus force to the knee, if the knee's fully extended, the other structures will actually help take on some of the force. However, if you have a partially flexed knee, it's really going to be primarily just the MCL. And we see this, so in athletic training, we learn special tests to test for the ligaments at the knee. When we want to test the MCL, we do a valgus stress test. When we want to isolate the MCL, we partially flex the knee. When we want to test for the MCL and some other structures, we do it with the knee fully extended. The LCL, you primarily have the same things going on. The difference with the LCL is that the LCL is not in the joint capsule like the MCL is, so the LCL kind of is separate from the joint capsule. So the ligaments also permit axial rotation with the knee flex. So when we have flexion at the knee, remember we said that's when you can actually start to get some rotational force taking place, and these ligaments will allow for that. Once the knee is fully extended, what the knee will essentially do is lock, and then you will not be able to get individual rotation at the lower leg. When we talk about the cruciate ligaments, the ACL, so we'll talk about the ACL and PCL together. So the ACL is a longer ligament, however the PCL is a much thicker and stronger ligament. With the ACL, you have what are known as anterior medial and posterior lateral bands. With the PCL, you have anterior lateral and posterior medial bands, okay? So those are basically different portions of those ligaments that can be affected differently based upon whether the knee's flexed, extended. Okay, so again, just to reiterate that, the ACL has anterior medial and posterior lateral bands. The PCL has anterior lateral and posterior medial bands. And again, the ACL is a little bit longer than the PCL. The PCL is a little bit stronger. And we know that ACL injuries are more common than PCL injuries. Then you have your other capsular ligaments. So these other capsular ligaments, for instance, you have what's known as the arcuate ligament. The arcuate ligament, it goes from the fibula to the posterior femur. You also have the oblique popliteal ligament, which goes from the medial condyle of the tibia to the lateral femoral condyle. And the jobs of those capsular ligaments are to help support the posterior lateral joint capsule. Many times the posterior lateral joint capsule can be susceptible to injury. A lot of times the posterior lateral joint capsule can also get damaged when you have an ACL tear, depending upon how severe the mechanism of injury is. So again, go through this and make note of, again, all of these ligaments, their different bands, and kind of what you look at as far as what occurs with the range of motion as we discussed. So the kinematics of the tibiofemoral joint, again, we talked about the degrees freedom of motion. So we have both flexion and extension and rotation of the tibia. Again, the only way you get rotation at the tibiofemoral joint is when the knee is flexed. As far as the range of motion, so the knee kind of goes out to, obviously 0 degrees would be full extension. On average, you get about 135 degrees of knee flexion. Again, kind of note what happens with the hip when you flex the knee, it will change kind of some of the dynamics. If somebody does have knee hyperextension, it's not abnormal to find that, although it usually shouldn't exceed 15 degrees of hyperextension. The joint end feels for knee flexion, it should be soft because you should be able to get approximation of the gastroc to the back of the thigh. Extension is going to be firm owing to the stretch of the hamstring tendons and the posterior soft tissue at the knee joint. The axes of motion for flexion extension are going to change due to the size of the femoral condyles, okay? So due to the size of the femoral condyles relative to the tibial condyles, that center of axis of rotation is always going to change. And there's also, again, that rolling and sliding that occurs that we're going to discuss. You also, in looking at axial rotation, so that takes place in the transverse plane. In terminal knee extension, again, the collateral ligaments are going to prevent knee rotation. So when your knee, again, is fully, completely extended, the collateral ligaments will become tight. You will not be able to rotate at the lower leg. So here's an important aspect of the biomechanics at the knee is the concept of terminal knee extension and the terminal rotation that occurs. This dynamic is known as the screw home mechanism. So when you flex and extend your knee, you actually do get some natural rotation to take place at the lower leg. So it's important that when you're looking at the motion at the knee, there's going to be that rotation that takes place, and your knee locks out when it's in full extension. So when we're talking about closed chain movement, now you're actually changing the dynamic. So when you flex and extend the knee in the open chain, as you extend your knee and you flex your knee, note what happens. Okay, so when you extend your knee, your lower leg is going to rotate laterally. When you flex it, it's going to rotate medially. That's in the open chain. When you look at closed chain motion, that dynamic changes because now your femur is moving on your tibia. And now you're actually going to get the opposite thing to occur. So again, open chain, you extend your knee, and it would help if you just do this now while I'm talking about it. You extend your knee, and notice your foot kind of turns out a little bit, or it should at least anyway. That's the lateral rotation that occurs with terminal knee extension in the open chain. When you flex it, it'll medially rotate. If you're now to go in closed chain, as you extend your knee, your femur will medially rotate on your tibia, okay, as you extend. When you flex, your femur laterally rotates on your tibia. So it's the opposite motion that occurs rotationally when you're looking at closed versus open chain. So take some time with that so that you kind of understand that coming into class. And again, part of this has to do with the surface architecture. Now, most of the pivoting is going to occur in the last 15 degrees of motion. However, the entire last 20 degrees of movement is what accompanies the screw home mechanism. So in both instances, whether it's lateral rotation of the tibia going in the open chain or the medial rotation of the femur in the closed chain, you get this screw home mechanism, which allows for locking of the knee and added stability when you're in full extension. Again, the pivoting is going to occur primarily during the last 15 degrees, but the last 20 degrees of movement accounts for the entire screw home mechanism. Now here we get into the arthrokinematics of the tibiofemoral joint. So we're going to talk first about closed packed and open packed positions. So the closed packed position of the tibiofemoral joint is full extension. The open packed is 25 degrees or more of flexion is going to be the open packed position. You have the convex concave relationships, and again, it's going to be important to note the difference between the open chain versus closed chain activity. So we'll talk about the open chain first, and then we have a picture here of the closed chain, which might actually help you appreciate a little bit more of the roll and slide relationship. So if we have open chain, extension, and flexion, okay, the tibia is your concave surface, okay? So again, it's not a real deep cave. It gets deeper with the meniscus, but we don't typically think of the tibial plateau as a very deep kind of cave, if you will, for a concave surface, but the menisci obviously help to deepen it as well. So when you extend the knee in the open chain, the roll and slide are both going to go anterior. When you flex the knee, the roll and slide are both going to go posterior, because again, they're going to go in the same direction because you have the concave moving on the convex. Now, when we look at the closed chain, because it seems like for the most part, everybody's getting when the concave moves on the convex, you know, the roll and slide going in the same direction. It seems like when it goes in the opposite, that's when confusion occurs, okay? So if we have closed chain flexion, okay, so now the tibia is fixed. So think of someone going into the bottom portion of a squat. That's what we're looking at here, okay? You now have, so we know that we have the convex femur moving on the concave tibia, okay? So as the knee flexes, so it's starting in extension, and the shaded kind of dotted area represents the end motion. So as the knee flexes, the roll is going posterior, the slide is going anterior, because you have the roll and slide going in the opposite direction. And what's neat about this picture is they're actually showing you the translation of the meniscus. So this is actually representing the meniscus, and we know as the knee flexes, the meniscus get pulled posteriorly by the two structures that we talked about that attach to it. Now when the knee extends, so now think of coming out of the bottom portion of the squat. So this is where we're starting. The shaded dotted area is where you end up. As the knee extends, now you get rolling anterior and sliding posterior. Okay, and again, they're showing the relationship of what happens with the meniscus here. Okay, so there you're seeing the roll and slide and the relationship in the closed chain. So again, take some time with that, because that may be something that you might have to think about a little bit more as far as the different topics related to this. Okay, so that takes us to the patellofemoral joint, obviously a very significant region in the knee as well. So again, within the knee, we talk about the actual knee joint itself, or the tibiofemoral joint, and then we have the patellofemoral joint. So the stability at the patellofemoral joint is going to be through both active and passive restraints. Now we talked about how the anterior projection of the lateral femoral condyle does kind of provide some stability, but really the stability at the patellofemoral joint is primarily achieved by a lot of the soft tissue. And as we kind of look at the different range of motion, so when you're in full extension, the patella is going to kind of sit up above the condyles within the fat pad. As you start to move through the range of motion, from about 0 to 20 degrees of range of motion, you're going to get greater stability from the VMO, or what's known as the vastus medialis oblique. And then as you flex even more, you're going to start to get greater forces from the lateral tissues. So the lateral structures are going to move posteriorly, and that's going to cause some lateral tilting forces to start to take place at the patella. And we're going to talk about the relationship between all of the little different movements that the patella does as you go through the range of motion in some of the slides that we have coming up. So patellofemoral joint kinematics. So first of all, it's important to note the difference between open versus closed chain activity again here. So whether the tibia is moving on the femur or the femur is moving on the tibia, that changes the dynamic as far as what the patella is doing. When you're in the open chain, the patella is going to move over the femur. When you're in the closed chain, the femur is going to move over the patella. So if you're operating in the closed chain, the patella is going to kind of be stabilized and the femur is going to move over that, and vice versa if you're operating in the open chain. Now, it's important to note that when you're going through open chain motion at the patellofemoral joint, what this is going to mean as far as the contact between the patella and the actual femur itself. So if we're looking at the movement of open chain knee flexion, so this is kind of getting discussed within the context of moving from extension to flexion. Okay, so open chain flexion, so we're starting at 0 degrees. Once we start to move to about 25 degrees of knee flexion, that's when the patella first has initial contact with the actual femoral condyles. Okay, so up until that point, it's actually sitting above them, and it's actually not even in contact with them because it's sitting above a fat pad inside the knee. So 25 degrees is where you're going to have the initial contact. 90 degrees is where you're going to get maximum contact between the patella and the femoral condyles. At 115, you're going to have contact with the condyles, but the sulcus is going to be present, so that's going to kind of reduce it a little bit. And then at 135 degrees, you're only going to have contact with what's known as the odd facet is going to contact the femoral condyles. So the contact between that will then start to gradually reduce again as you go through. So 90 degrees is where you're going to have kind of the maximum contact, and at, once you get beyond that, then the contact area starts to get reduced a little bit more. So here's what we said. There's a lot of little movements that take place at the patella when you're going through this movement. So we look at static and dynamic alignment. So the movements, the arthrokinematic movements that the patella is going to do, there's going to be medial lateral shift, there's going to be patellar tilt, there's patellar flexion, and then there's patellar rotation. Okay? So again, shift, tilt, flexion, rotation. So the position at 90 degrees, so this is an important thing to kind of note. So at 90 degrees, so meaning your knee joint's at 90 degrees, the patella is flexed, it's laterally shifted, and it's laterally tilted. Okay? So that's going to be the position when the patella is at 90 degrees. Okay? When your static position of the patella, when it moves as far as when you're in full extension, it's going to lie in the intercondylar groove. So again, there's not going to be any real change in motion there, and there's not a whole lot as far as forces applied in that situation. We look at the concepts of patella baja and patella alta. So patella baja is a low riding patella, meaning it tends to ride a little bit lower than normal. And there's what's known as patella alta, which is when you have a high riding patella, where the patella actually kind of sits naturally in a little bit more of a higher position in the knee. And an important thing to note about that is that's actually something, again, you can test for, because sometimes people that have issues at their patellofemoral joint, so there's actual measurements you can take to determine if somebody actually has a patella baja or a patella alta. And again, part of what we look to do, because the patella, typically if the patella is going to have some sort of instability or issue, it's going to be lateral displacement is going to be more of the problem. So what we want to try to do is kind of limit any type of lateral displacement, and that's kind of the whole idea behind the stability at the patellofemoral joint. So again, this might be an instant where you might want to pause the video, kind of just, again, reassess your notes. So again, when we look at this different motion that occurs, again, when the knee is relaxed in full extension, the patella lies in the proximal intercondylar groove, doesn't really have a whole lot of motion. As the knee flexes and extends, the patella moves, okay? And it's going to move in these directions as we talked about. Again, at 90 degrees of flexion, your patella is going to be flexed, laterally shifted, and laterally tilted as you're going through your flexion range of motion. So, and again, look at all of these different illustrations so that you can kind of see how those motions relate. And probably when we're looking as far as the full excursion of the patella, so the patella is going to move, as you move from extension to flexion, it moves about 5 to 7 centimeters, okay? And again, you're going to have these other secondary motions that are going to kind of occur. Again, you're going to get your stability provided by the soft tissues. Most of the time, again, the issues with lateral displacement are going to be caused by tightness from the IT band and weakness from the VMO, and that's going to cause an imbalance with some of these issues as far as how the patella is actually moving inside the, or I guess in the anterior portion of the knee. So still looking at the arthrokinematics. So looking at the concave and convex surfaces. So the posterior aspect of the patella is your concave surface. So obviously the femoral condyles are going to be your convex. With the open and closed pack position, so the resting position is going to be full extension. So when the knee's fully extended, you could kind of even feel this for yourself. With your knee fully extended, you could kind of move your patella a little bit more with your, you could just take your fingers and kind of grasp it, you kind of slide it around. The closed pack position is going to be full flexion, or just any type of flexion. It's going to start to sit into that region as we discussed previously. The gliding with flexion and extension. So again, we talked about a 5 to 7 centimeter excursion of the patellofemoral joint. As you flex the patellofemoral joint, it's going to glide inferiorly. As you extend the knee joint, the patella is going to glide superiorly. Okay, and again, that kind of coincides with just what we talked about in the previous discussion. So again, even go back, note the difference with shift, tilt, whether you're getting flexion or extension at the patella, and what's going on as far as rotation at the patella as well. So look at some things that we kind of examine from the standpoint of function with the patellofemoral joint. We look at what's known as the Q angle. So the Q angle, or we also call the quadriceps angle, so this impacts forces at the patella, and in individuals who have patellofemoral problems, this is sometimes that we find to be problematic. So when you measure the Q angle, this is something that athletic trainers do clinically. So what you do is you kind of take an angle of a measurement going straight through the patella, and you take an angle that coincides with the ASIS. And that angle represents the Q angle. Why that's significant is because the bigger this Q angle gets, if you think about, again, your force vectors, this is where that force vector thing becomes important. The larger this Q angle gets, the more the patella is going to have a tendency to want to kind of get pulled laterally, okay? In men, normal Q angle measurements are between 10 and 14 degrees. In women, normal is 15 to 23. So women naturally do have a bigger Q angle because of the shape of their pelvis. And again, that could predispose to possibly some greater issues at the patellofemoral joint, particularly if they have Q angles larger than 23 degrees, which can happen. So that really large Q angle is going to impact the pull of the quadriceps on the patella and impact its alignment within the condyles of the femur. Now here's where we get into some muscle function. Again, it's really important that you kind of understand the muscle function for everybody from a strengthening perspective, what it means as far as concentric and eccentric contraction. So again, contraction type is going to be based on function. So we've talked about all the different types of contraction, of muscle contraction. So concentric is going to occur anytime your muscle's accelerating. Eccentric is going to occur anytime you're decelerating. And isometric is going to occur anytime you're stabilizing. Okay? So here's a question that I want to bring up. So when we're looking at the knee extensors, and I'm going to have you kind of bring this with you to class, which knee extensor is a two-joint muscle? So there is a knee extensor that is a two-joint muscle. And kind of with that, what would be the optimal position for it to function as a knee extensor? Okay, so we talked about the whole concept of optimal sufficiency. What does it mean when you have a two-joint muscle? So for that muscle to work at the knee, okay, what position does the other joint have to be in? Okay, so it's going to cross both the hip and the knee in order for it to work more optimally as a knee extensor. What position does the hip have to be in order for that to take place? Mention the vastus medialis oblique. So off the vastus medialis muscle, you have the vastus medialis oblique, and it's called that because of the way the fibers run. And that's going to provide added medial stability. So we want to make sure that that area is strong enough to be able to maintain stability at the patellofemoral joint. Another one I want you to look up and see. So given that we have two joint muscles, we have muscles coming from different angles, what is the most efficient knee extensor of all of the muscles that produce knee extension? Okay, and you can't just say the quadriceps, because the quadriceps is made up of different muscles. In particular, which quadricep muscle is the most efficient knee extensor? So make sure you look that up and put that in your notes, and we'll bring that up again in some function in class. All right, so looking at the muscle function of the knee flexors. So again, we look at the hamstring muscle group. Again, look at the hamstring. We know the close relationship of the knee and the hip. So the hamstrings, all the hamstrings are a two-joint muscle. If we look at open chain versus closed chain, so in the open chain, the hamstrings look to flex the knee. In the closed chain, we primarily look at them as extending the hip functionally. They also have contributions to knee rotation, as do other muscles. So the muscular contributions from the hamstring as far as rotation, the semimembranosus and semitendinosus will medially rotate the tibia, along with the popliteus, the gracilis, and the sartorius. So those are also, now they're not all hamstring muscles. Obviously, only the semimembranosus and semitendinosus are hamstring muscles. But the sartorius, gracilis, and popliteus will also medially rotate the tibia. With the lateral rotation of the tibia is going to come from the biceps femoris. It's the lateral hamstring muscle. And again, the functions with walking, so it's important to help that these muscles help with rotation at the knee, because as you're walking, your lower leg is going to have to rotate based upon where you are in the gait cycle. And we'll be talking about, we're basically going to be spending a whole chapter talking about walking gait. Again, the cause of most hamstring strains, so the hamstrings are an important muscle group to talk about with muscle strains, and they're kind of they kind of pose some challenges. The most common mechanism of hamstring injury is through sprinting, okay? And the biceps femoris with sprinting tends to be the most commonly strained hamstring. So usually with hamstring strains, you talk about two different mechanisms. You talk about more of a stretch type strain, which tends to happen more commonly in the medial hamstrings, and then you have through a sprint, which more commonly occurs to the lateral hamstrings. And again, that can kind of flip and flop. Certainly there are exceptions to that, but that's more commonly what happens. Now with sprinting, they think that most of the strains are going to occur during the terminal swing phase, when the hamstrings are actually acting as a decelerator to the knee extension that occurs as you're kind of swinging your leg through. So if you think about it, as your leg kind of swings through, the tibia has to slow down eventually. You don't just kind of kick wildly. And what the hamstrings do is contract eccentrically, and that's the belief where they think most of the hamstring strains occur. That's something that does get argued a little bit. They actually, there are some people that actually think it's more of the initial contact when the foot strikes the ground that causes it. Either way, I think that argument doesn't really matter, because I think when we just look at sprinting being the cause, I think that's more or less what has to be addressed. And then we look at the popliteus. So we said that the popliteus is going to medially rotate the tibia. And that happens in the open chain, but interestingly enough, when you go in the closed chain, now the popliteus actually acts on the femur. And the popliteus on the femur in the closed chain actually does lateral rotation, okay? So The popliteus does stabilize the knee, but the other thing that it does is it works to unlock the knee when it's in terminal extension. So when you terminally extend your knee, when you go to flex the knee, the popliteus muscle is responsible for unlocking that. In the open chain, it medially rotates the tibia. And in the closed chain, it's going to unlock terminal extension by laterally rotating the femur. Because remember, when you terminally extend in the closed chain, the femur now is going to rotate medially on the tibia, which in order to unlock that is going to do lateral rotation. So in the open chain, rotates the tibia medially on the femur. Closed chain rotates the femur laterally on the tibia. Again, also provides some stability. So 1 and 2 joint muscles at the knee. So we know that we have our 2 joint muscles. We kind of talked about them briefly. Again, I want you to tell me which knee extensor is a 2 joint muscle. Again, what this does allows for more efficiency, and it helps to produce motion in multiple planes. So even when you think of something as simple as walking, it just kind of allows for much more efficient movement. And the reason why, you're always going to have that kind of optimal sufficiency, as you will, that we talked about, is that it's seldomly going to work at both joints at the same time, meaning that you're not going to have both the hip and the knee working. And that's where, again, some people are still getting confused when we look at concentric and eccentric actions. So again, you're not going to have a concentric motion at the hip and an eccentric motion occurring at the knee, okay? They're not going to work at both joints at the same time. When the hamstrings are working at the hip, they're not working at the knee, okay? And the same would be said for the 2 joint muscle that does knee extension. So when we look at these different motions that are going to occur at the knee, so what I want you to do is, and again, this is going to be something that we're going to do in class as a part of the lesson here. So we have all of these different positions. I want you to tell me what is going to happen with each of these motions. So when you have knee flexion combined with hip extension, when you have knee extension combined with hip flexion, knee flexion combined with hip flexion, knee extension combined with hip extension, knee flexion combined with plantar flexion. Because remember now, the gastroc, while we think of it as an ankle joint muscle, the gastrocnemius actually crosses the knee joint. So technically there is some knee function from the gastrocnemius. Obviously the soleus only really impacts, for the most part, the ankle joint. And then knee extension combined with ankle plantar flexion. So take your time with this. You can also kind of, again, you could kind of get your answers from the book, but I want you to think about it first, then check yourself with the book so that you could kind of see. So what do we look at as far as active and passive insufficiency? Do we have functional combinations? Do we have any situations where we would have active insufficiency, passive insufficiency, functional combinations? That's what I want you to be looking at with this, and make sure you prepare that prior to coming to class. Now, tibiofemoral joint forces. So it's important to look at, again, this is kind of another functional thing as it relates to stress on some of the tissues that we look at. And this is kind of what we're looking at here going through the remainder of the chapter. So as we're looking at tibiofemoral joint forces, so forces across the joint are going to increase when we look at different activity. So shear stresses are going to be experienced with knee range of motion. So shear stresses at the knee are going to be anterior posterior forces that occur. And again, because we have natural restrictions to anterior and posterior forces. However, if too much force is applied, we're going to have issues related to the knee joint. And we know that excessive forces over time can promote degenerative joint disease. So it's important to look at stresses in the open and closed chain. Now, this is an important chart to look at. So again, make sure before you leave this slide that you kind of understand what's going on here. So we look at both open and closed chain motion, and we're looking at range of motion at the knee. Okay, so the blue represents the patellofemoral joint. The solid line is in closed chain. The dotted line is in open chain. Same thing with the ACL, except now you're looking at a red line. Okay, so notice what happens as we look at range of motion. So 0 degrees would be full extension, and you're moving into degrees of flexion. If we look at the closed chain activity, as you go into deeper and deeper ranges of motion in the closed chain, notice what happens with the joint stress at both the patellofemoral and essentially at the knee joint with the ACL. You see a rise. Now you see a much sharper rise in the patellofemoral joint, but you also see it with the ACL. So in the closed chain, as you go into deeper and deeper ranges of motion, you start to notice that you have greater stresses at the respective joints and with the structures. If we look at the closed kinetic chain, or we look at the open kinetic chain rather, so the open kinetic chain is the dotted line, you actually see the opposite. You actually see the stresses rise as you get into terminal knee extension, okay? So you see the stress rise at the patellofemoral joint, and you see the stress rise at the ACL. So note this relationship. Now there's that kind of crossover point with each one of them. So this is important when you're dealing with somebody that has a pathology, so that you know in both the open and closed chain how it's supposed to work. So when you're weight bearing, there's actually less stress to the ACL and patellofemoral joint in the first half of knee motion, and it's just the opposite when you're looking at open chain activity. Here's another thing that's kind of important to note. So the forces tend to move medially when walking and when you're in unilateral weight bearing. So here we see in normal full weight bearing how the forces are kind of going through the knee joint and how that's going to impact the patellofemoral joint. However, when you go into unilateral weight bearing and walking, which you do go unilateral weight bearing when you do walk, you see how the forces kind of move medially. Now, this is an important thing to consider when we talk about those things like Q angle, when we talk about being able to assess someone's gait and how it impacts their knee. So, if you have, a gait abnormality that produces too many forces kind of coming out this way, how that impacts that force and what that's going to mean for both the knee joint and the patellofemoral joint. Okay, so again, in normal walking, the force and unilateral weight bearing, the forces are going to move medially. That's an important consideration when you're kind of looking at sort of some of the function and what that means as far as when people have kind of abnormal forces coming through the knee joint. So when we look at patellofemoral joint forces, so if we look at the idea behind squatting and what that means as far as the joint surfaces, I mean, again, first of all, again, go back and review your function at the patella. But when we look at patellofemoral compression forces and contact stress, so we talked about this a little bit. So we noted how in the closed chain, the greater degree of knee flexion, the greater amount of stress is going to occur, or the greater amount of forces are going to be increased. So you're going to have greater stress at the patellofemoral joint. Whereas when you are in the open chain, it's the opposite. So now that would make most people to think that, well, if you squat to 90 degrees, you're going to actually have a lot of damage at the, you could have issues at the patellofemoral joint. And that's true. Interestingly enough, though, the closed chain extreme motion is actually less stressful to the patellofemoral joint than the open chain version. So in other words, if you had to pick which one's going to cause more problems, the squatting to 90 degrees is actually going to be less stressful to the patellofemoral joint than going into full terminal open chain knee extension. The reason being is that the contact stress is actually increased with the closed chain motion. Now, if you're sitting there saying, well, why would that be better? The reason being is the surface area, it actually gets dispersed more when you're in the closed chain. So what you have to see is go back to, well, what actually happens with the patella as it relates to the contact area as you go through that stressful region. So when the stressful region is occurring in the closed chain, you actually have greater surface area of the patella in contact with the femur. What that does is that disperses the stress. So instead of having these smaller areas of high stress, it's kind of spread out a little bit more throughout the patella. So that actually what makes the closed chain activity a little less stressful. Again, the stresses are still going to increase, but it's going to actually be less potential for damage or issues with the articular cartilage than you would with actual open chain motion. Because in the open chain, when you get into that stressful region, there's actually less contact area, which means that the stresses are actually going to be increased. So when you think about just compression stress, the more you can disperse stress over an area, that actually makes it less stressful overall. That's why we wear, for instance, why in sports we wear protective padding, because when you wear padding, it disperses the force. Same idea when you look at closed chain versus open chain motion here. So when you look at this again here, now again, there's numerous issues that might occur in a situation where, somebody has an issue like this going on with their posture. But here you're seeing a situation where one of the things that could happen over time is you can start to get damage to or at least stress or inflammation to the posterior aspect of the patella. Again, here you're kind of increasing. So now here you have like what we call more of a dynamic Q angle. So obviously this isn't her normal Q angle, but what this is going to do is cause the patella to shift laterally and cause structural damage or just even irritation to the posterior aspect of the patella. In addition to that, this also puts the ACL, if she's landing like this, again, the knee is not meant to have frontal plane motion. So here you're getting that frontal plane motion at the knee joint, which again, the knee is not meant to bear, and that could also cause damage in that aspect as well. So we look at muscle torques. So just some information as it relates to how the muscles will actually work. So for the knee extensors, the peak torque is at about 60 degrees. So at about 60 degrees of flexion, if the knee extensors work from that position, that's where they can get their peak torque. Due to the patella, the knee extensors kind of maintain their strength really well in the range of 30 to 80 degrees. So even outside of that 60-degree range, there's still some added increased torque that can occur. The issue of extensor lag is important. So this is always something you want to avoid with a knee injury. So an extensor lag is where an individual kind of gets a dysfunction at their knee where they can't terminally extend their knee and there's some weakness present there. So you really want to make sure when you're rehabilitating somebody, they get that knee extension back and that their knee extensors can support that. With the knee flexors, as far as looking at position for maximal torque, the position for maximal torque of the hamstring muscles is going to be greatest when the muscles are elongated at both the hip and the knee. So when you have the hamstrings elongated at the knee and you have them elongated at the hip, that's where you're going to get your greatest amount of knee flexion torque. And the reason for that is length is really your predominant factor for force generation when you're looking at the knee flexors. Okay, so again, important to note what your positions are here as far as muscle torques at the knee. If we're looking at hamstring to quad ratios, this is always something that comes up with a lot of different injury issues. So the quadriceps is actually going to have the greatest amount of torque, okay? So the peak torque of the quadriceps are greater than those of the knee flexors. And again, it just makes sense because the cross-sectional area of the quadriceps is much greater. It's a much bigger, thicker muscle. So that's the primary reason why. A normal ratio, or what at least most people shoot for normal function, is a ratio of 2 to 3, meaning that you want the hamstrings to have at least 66% approximately of the strength of the quadriceps. If you can make them stronger, that's even better. Some people through training can actually make their hamstrings stronger than their quadriceps, which actually shows a major reduction in a lot of knee issues. And again, this is something that we see many times with males versus females as far as their muscular development. So they've found in studies that more mature males demonstrate a greater percentage of increased strength in their hamstrings, whereas more mature females actually show increase in quadriceps strength. So that's one of the reasons why then we get concerned, particularly about ACL injuries in females. Again, if you think about what the hamstrings would do in preventing ACL injuries, the hamstrings put a posterior force on the tibia, which would take stress off of the ACL. So that's one of the reasons why we think that there's a possible contribution there to a lot of your hamstring injuries. We have a lot of muscle and ligament interaction at the knee with the muscles that cross the knee joint and obviously some of the ligaments. So the sensory function and reflexes that are going to occur. So we already talked about the hamstrings and their facilitation to protect the ACL. I just mentioned again just some studies showing that again more mature, physically mature males have a greater strength in their hamstrings, whereas females tend to have greater strength in the quadriceps. Again, being one of the things that could predispose as far as ACL injuries. With joint capsule swelling, that's going to actually impact the sensory function and the reflexes. So if someone does have swelling inside their joint capsule, that could predispose them to injury because they could get a reflex inhibition of some of those muscles that look to protect the knee joint. So it's really important if somebody does have a lot of swelling inside the knee, number one, you find out what's causing it because it shows that there is some type of internal derangement, and then they get appropriate rehabilitation. And again, decreased proprioceptive abilities and ACL tears. So when you start to lose, if somebody does have an ACL tear, that's one of the reasons why that normally has to get reconstructed, because the ACL provides significant sensory information back to the central nervous system to be able to sense where your knee joint is. So the ACL is a significant contributor to proprioception in the knee. There's static and dynamic contractions. This is regulated as well. So the semimembranosus and the IT band. So the semimembranosus is capable of tightening up the joint capsule. So that allows for that to occur. The IT band also has some connection to the joint capsule as well. The popliteus also has some contribution to the static and dynamic contractions. We had talked about how the popliteus does provide some stability to the knee. And the popliteus also has a connection to the joint capsule, so that's going to further allow for that. And then the attachments to the meniscus. So the meniscofemoral ligaments help to mobilize the lateral meniscus and prevent it from getting trapped inside the knee joint. So those attachments to the meniscus are also going to by the joint capsule, and in particular the meniscofemoral ligaments mobilizing the lateral meniscus are going to allow for normal function of the meniscus as you're going through your range of motion. And again, some further muscle and ligament interaction. Again, the muscles are going to help protect the ligaments as we already talked about, okay? And again, just even with basic walking. So with walking, the hamstrings help to decelerate the tibia. That's going to be a normal thing that it does. Obviously, that it becomes a much greater function when we talk about running. The popliteus both stabilizes and unlocks the knee. So make sure you understand how the popliteus unlocks the knee, rather. The popliteus unlocks the knee while you're going through your knee range of motion, particularly with walking. The soleus and the gastroc. Now, we talked about the gastroc, but interestingly enough, the soleus, while it does not cross the knee joint, so the soleus does not cross the knee joint, it will actually contribute to knee extension. So there's actually when a muscle is going to work somewhere else where it doesn't cross, it's something known as dynamic coupling. So the soleus locks the foot while you're weight bearing. What that actually does is it contributes to knee extension, because as your foot is locked, it kind of provides that stable base, which then allows for further knee extension to occur. So again, let me repeat, it's not operating directly at the knee joint. I am not saying that the soleus extends the knee by its function. However, because of what it does at the foot, it allows for greater knee extension to occur when you're weight bearing. And we know that the gastrocnemius obviously can help control extension eccentrically because it does act as a weak flexor of the knee concentrically. And then again, I've kind of mentioned pathological situations as we've kind of moved through this discussion. But when we just look at someone again who's ACL deficient, so if someone who tears their ACL and does not get it reconstructed, you do have specific things that occur. We already mentioned the sensory deficits that you get and how that impacts your proprioception. But the other thing that tends to happen is you get earlier recruitment of particularly the medial gastroc, quads, and hamstrings because of the fact that you're losing that sensory input from the ACL. So if someone is ACL deficient, chooses not to get their ACL reconstructed, which most active people don't choose to do, but you need to work on the timing of those muscular contractions, because again, they're all going to get recruited much earlier because you're not getting that feedback from the ACL when it's been torn. Okay, and again, that's again primarily the reason why most people will go and get their knee joint reconstructed, because they don't have as much stability. You do tend to get greater degenerative changes at the knee joint that will occur in that situation. And these are all of your learning outcomes. So again, make sure you come prepared for class, which you can easily do. Even if you struggle a little bit with those questions that I brought up, they can all be answered in your textbook. So you should come to class with that information prepared because we will do an activity associated with that. So make sure that you have completed that, looked over it. If you have any questions before we meet in class about that information, just feel free to email me.